Hello viewers, welcome to my channel. I am Puspen Dasgupta, an Indian ENT specialist, and I upload new videos on YouTube at 9 p.m. Indian Standard Time every day of the week. Each day of the week subscribes to a particular theme, and the theme for Monday, that is today, is postgraduate ENT theory exam. I did feel during my tenure as a postgraduate trainee that constructing answers for theory exams is an unenviable task, because the answers need to be both comprehensive and succinct. Comprehensive because they carry 10 marks each, and succinct because one had to finish writing them in 15 minutes. Striking this balance is particularly difficult, and this is my attempt to create sample answers for the benefit of postgraduate ENT students so that they can read these answers and prepare better answers so that they can do extremely well in their postgraduate ENT exams. So without further ado, let's get into the meat of the discussion. Today's topic is deep neck spaces. This is the question that has been asked frequently in MS ENT theory exam, and the question today is describe the different deep spaces of the neck, state the surgical importance of each. So let's get into it. Deep neck spaces are several anatomical compartments containing only loose areolar tissue in healthy subjects. Deep neck spaces lie between facial layers of the neck. Facial layers limit the spread of infection. However, interconnected deep neck spaces can act as routes of transmission of both infection as well as neoplasia. Now, it is important to know the different facial layers of the neck to understand the neck spaces. However, you can choose to skip this part just to keep your answer brief. What are the different facial layers of the neck? There is the superficial cervical fascia and there is the deep cervical fascia. The deep cervical fascia in turn has three layers: the superficial layer, the middle layer, and the deep layer. We will talk about them in greater detail in subsequent minutes. It is important to identify the fascia because it allows dissection within a safe and relatively avascular plane during neck surgery. Let's first talk about superficial cervical fascia. Superficial cervical fascia invests platysma muscle. It is penetrated by small vessels supplying skin. Subplatysmal flaps are raised during neck surgery to preserve the blood supply to the skin. Inferiorly, an aponeurosis is created that either attaches to skin or becomes continuous inferiorly with the fascia covering deltoid and pectoralis major muscles. Now let's talk about deep cervical fascia. The superficial layer of deep cervical fascia is called the investing layer. For the sake of humor, we can call it the Warren Buffett layer. However, please don't write Warren Buffett in your theory exams. The Warren Buffett layer forms the facial cylinder. This facial cylinder contains all of the neck nodal stations and most structures of the neck. Investing layer arises from ligamentum nuchae and the spinous process of the cervical vertebrae. Investing layer invests the entire neck. Investing layer divides to enclose sternocleidomastoid muscle, omohyoid muscle, infrahyoid muscles, and trapezius muscle. Superiorly, investing layer is attached to mastoid tip and zygoma and at the superior nuchal lines. Investing layer splits to enclose parotid gland, becoming the parotid fascia. Deep layer of parotid fascia fuses with fascia of internal carotid artery. Anteriorly, investing layer attaches to hyoid bone. Inferiorly, investing layer attaches to acromion, clavicle, and sternum. Now let's talk about carotid sheath. Carotid sheath is derived from investing layer of deep cervical fascia medial to sternocleidomastoid muscle. Carotid sheath encloses the following. Surprise, surprise, carotid sheath encloses common carotid artery, and after bifurcation, external and internal carotid artery. Carotid sheath also encases internal jugular vein and vagus nerve. Carotid sheath is thicker around arteries and it is loose around internal jugular vein to allow expansion during times of increased venous flow. Carotid sheath is connected to other facial layers by loose areolar tissue. Now let's talk about pretracheal fascia. Pretracheal fascia is also derived from investing layer of deep cervical fascia. Pretracheal fascia is the middle layer of deep cervical fascia. It is also known as visceral layer. Superiorly, it is attached to hyoid bone. Pretracheal fascia has two parts: muscular compartment and visceral compartment. Muscular compartment encases infrahyoid muscles and visceral compartment contains trachea, thyroid gland, pharynx, and upper esophagus. Pretracheal fascia inferiorly fuses with the fascia of superior mediastinum around the great vessels and the fibrous pericardium. Laterally, pretracheal fascia connects to the carotid sheath by loose areolar tissue. Now let's talk about prevertebral fascia. Prevertebral fascia is the deepest layer of cervical fascia. It encompasses posterior neck muscles, scalene muscles, and vertebrae. Prevertebral fascia forms the floor of posterior triangle. It represents deep limit of neck dissection and also represents plane between cervical vertebrae and upper aerodigestive tract. Prevertebral fascia allows pharynx to move freely during deglutition. A supplementary layer of fascia known as alar fascia lies anterior to the prevertebral fascia, which extends from skull base to posterior mediastinum to the level of second thoracic vertebra. The space between alar fascia and prevertebral fascia has been described as danger space, and we will describe danger space in subsequent minutes. So stay tuned. Now, what are the different neck spaces or the different deep neck spaces? There is the submental space, the submandibular space, peritonsillar space, parapharyngeal space, retropharyngeal space, prevertebral space, carotid space, parotid space, visceral space. So submental, submandibular, peritonsillar, parapharyngeal, retropharyngeal, prevertebral, carotid, parotid, visceral. It is very important to write the different spaces in the very beginning so that one can refer back to it in case one forgets one of the many spaces mentioned here. Let's describe submental space first. Submental space, we will first describe the boundaries. Lateral boundary of submental space are the right and left anterior bellies of digastric muscle. Inferior boundary is the body of hyoid bone. Superior boundary, mental process of mandible. Superficial limit is superior cervical fascia, and deep limit is mylohyoid and geniohyoid muscles. Now, what are the contents of submental space? As previously stated, all deep neck spaces in healthy individuals only contain loose areolar tissue. However, submental space can also contain level 1A lymph nodes and some small veins that drain into anterior jugular veins. Let's go on to submandibular space. Submandibular space superior limit is mucosa of floor of mouth, inferiorly investing layer of deep cervical fascia from mandible and hyoid bone. Antero-inferior boundary of submandibular space is anterior belly of digastric. Posterior-inferior boundary of submandibular space is posterior belly of digastric. Superficial limit is investing layer of deep cervical fascia. Floor is formed by hyoglossus muscle. Mylohyoid muscle divides submandibular space into superior compartment and inferior compartment. The route of spread of infection between the neck and floor of mouth can be submandibular space. Now, superior and inferior compartments communicate around the free posterior edge of mylohyoid. Superior space is also known as sublingual space. Sublingual space contains sublingual salivary gland, deep part of submandibular gland, lingual nerve, lymph nodes, and branches of facial vessels. Submandibular space has an inferior compartment which contains superficial lobe of submandibular gland, lymph nodes, and branches of facial vessels. Swelling in submandibular space is limited by attachments of mylohyoid muscle and deep fascia. Distension of submandibular space occurs in a cephalic and medial direction. Submandibular space infection can lead to Ludwig's angina. Ludwig's angina is a life-threatening airway complication of submandibular space infection. Ludwig's angina is typically characterized by rapid onset of cellulitis of floor of mouth tissue. There is swelling in duration and elevation of tongue which results in a compromised airway. Most commonly, submandibular space infections are odontogenic in origin, that is originate from teeth infection. Submandibular space infection can also be due to submandibular sialadenitis, lymphadenitis, trauma, and following surgery. Now let's talk about peritonsillar space. Peritonsillar space is a potential space. It is between palatine tonsil and superior constrictor muscle. Tonsillar capsule is formed by condensation of pharyngobasilar fascia. This tonsillar capsule can get breached by bacterial infections of tonsil. This breach of tonsillar capsule can result in abscess formation in the peritonsillar space, and this abscess in peritonsillar space is known as quinsy. untreated peritonsillar space infection may spread to involve parapharyngeal space. Now, parapharyngeal space is an inverted pyramid shaped space. It extends from petrous temporal bone superiorly to hyoid bone inferiorly. Medially, parapharyngeal space is bounded by superior constrictor muscle. Laterally, parapharyngeal space is bounded by pterygoid muscles, parotid salivary gland, and mandible. Styloid process and its attachments divide parapharyngeal space into pre-styloid and post-styloid compartments. Let's talk about pre-styloid compartment. Pre-styloid compartment of parapharyngeal space contains fat, connective tissue, maxillary artery, inferior alveolar nerve, lingual nerve, and auriculotemporal nerve. Lesions of pre-styloid compartment are most commonly associated with deep lobe of parotid gland. Lesions of pre-styloid compartment deflect carotid sheath and parapharyngeal fat posteromedially. Determination between pre-styloid and post-styloid involvement and displacement of the parapharyngeal fat pad are key radiological features which help in diagnosis of parapharyngeal space neoplasia. Let's talk about post-styloid compartment of parapharyngeal space. Post-styloid compartment contains carotid sheath and its contents, glossopharyngeal nerve, hypoglossal nerve, sympathetic chain, and lymph nodes. Lesions of post-styloid compartment are frequently of neuroendocrine origin like carotid body tumors, vagal schwannoma, neuroma of sympathetic chain. Post-styloid compartment lesions displace parapharyngeal fat anteriorly. So just to repeat, pre-styloid compartment lesions displace parapharyngeal fat posteromedially, whereas post-styloid compartment lesions displace parapharyngeal fat anteriorly. Now, surgical access to parapharyngeal space may require mobilization of parotid gland or lip split mandibulotomy. Central connection is present in the parapharyngeal space, so this infection from this space can spread to other deep neck spaces. Parapharyngeal space is a common site for deep neck space infection and abscess formation. Abscesses of parapharyngeal space spread from peritonsillar space. They can be due to orodental causes leading to submandibular space infection which later spreads to parapharyngeal space. If left untreated, parapharyngeal space abscesses can readily result in airway compromise. Abscesses of parapharyngeal space can produce medial displacement of palatine tonsil. Medial displacement of lateral oropharyngeal wall may also be seen in abscesses of parapharyngeal space. However, neck swelling or asymmetry may or may not be present in cases of parapharyngeal space abscess. Trismus may also occur secondary to inflammation of pterygoid muscles in abscesses of parapharyngeal space. The two parapharyngeal spaces communicate with retropharyngeal space posteriorly, and parapharyngeal space infection may readily spread into retropharyngeal space. Now let's talk about retropharyngeal space. Retropharyngeal space lies between the two parapharyngeal spaces. It is continuous with both parapharyngeal spaces. Superior limit of retropharyngeal space is the skull base. Inferiorly, retropharyngeal space is continuous with the posterior mediastinum down to the level of carina. Anterior limit of retropharyngeal space is buccopharyngeal fascia, which encases pharyngeal constrictors. Posterior limit of retropharyngeal space is alar facial component of prevertebral fascia. Contents of retropharyngeal space are the retropharyngeal lymph nodes, which typically regress by adulthood. So, if there is radiological evidence of retropharyngeal lymphadenopathy in adults, it raises the suspicion of head and neck malignancy. So, retropharyngeal lymph nodes represent a route of metastatic nodal spread from midline or posterior tumors of the pharynx. Parapharyngeal space infection can spread to retropharyngeal space. Retropharyngeal space infection can happen secondary to perforation of pharynx or cervical esophagus. Retropharyngeal space abscesses are seen more commonly in children than in adults. Abscesses may be secondary to infection of the upper aerodigestive tract. Abscesses may result in airway obstruction due to anterior displacement of airway. Alar space is colloquially known as danger space. Alar space lies between the prevertebral fascia and alar facial component of prevertebral fascia. Alar space extends to the level of diaphragm. Alar space is only visible radiologically if it is distended due to collection within this area. Alar space is also known as danger space because neck infections have a potential to readily spread into thorax and cause mediastinitis. Now let's talk about prevertebral space. Prevertebral space is a potential space. Anterior boundary of prevertebral space is the prevertebral fascia. Posterior boundary of prevertebral space are the vertebral column and the paraspinal musculature. In prevertebral space, infection may be due to traumatic perforation of pharynx or traumatic perforation of esophagus or breach of prevertebral fascia due to retropharyngeal infection. Infection of prevertebral space can cause spinal osteomyelitis and spinal cord compression. Invasion into prevertebral space can be seen in head and neck malignancy, and if it is present, then this is a feature which often signifies inoperable disease. Now let's talk about carotid space. Carotid space is also a potential space. Carotid space lies within carotid sheath. Carotid sheath is formed by condensation of all three layers of deep cervical fascia. Contents of carotid space are the common carotid artery, internal jugular vein, and vagus nerve. After carotid space, we will talk about parotid space. Carotid space and now parotid space. Parotid space is formed by investing layer of deep cervical fascia. This investing layer, or the Warren Buffett layer, splits to encompass the parotid gland. Contents of parotid space are facial nerve, retromandibular nerve, and terminal branches of the external carotid artery. Again, please don't write Warren Buffett layer in your exam. Visceral space. Anterior boundary is middle layer of deep cervical fascia that envelops thyroid and trachea. Posterior boundary is pretracheal fascia. Visceral space contents are different viscera like larynx, hypopharynx, cervical esophagus, proximal trachea, thyroid gland, parathyroid gland, and level 6 lymphatics. With this, we come to an end to this theory answer on deep neck spaces. You can choose to skip writing about facial layers, but I feel if you write about it, then you get a more comprehensive answer. However, if time is of the essence and you are not in a position to write such a lengthy answer, then please skip the facial layer description. I hope you like this answer. Take care. Bye-bye. Leave a comment telling me which topic you want me to talk about in next week's video. This video was suggested by Dr. Annesha Dondapat and I made it. So if you have any more suggestions, I'll be happy to oblige. I hope I'll see you in the next video very, very soon. And please don't forget to be awesome.